So the goals today are pretty simple. Go through this from the typical pathoanatomy, et cetera, and then but I want to take a few calculated spur roads with you to kind of say this is a microcosm of how we educate patients. We're going to go through, I did a little search last night, just looking at a couple of Google forums on frozen shoulder. It doesn't take 3 reviews of some of the YouTube videos out there to kind of say this is a perfect microcosm of what your patients are thinking. A little lit review, very brief lit review with it. And then we're going to talk about how the literature, how would you do literature or a study on a frozen shoulder? So just kind of a flashback to scrupulous article reviews. So 2 main types, post-traumatic or post-surgical, and idiopathic. Idiopathic meaning what? That's right. I don't know. Right? Yes. So, with a frozen shoulder, is it good or bad to tell a patient you don't know why it happened?
I tell patients that with research, they still don't know what's going on with frozen shoulder.
Good.
So I don't know either.
So is that engender confidence or fear in your patient?
I always say that people that have diabetes are at a higher risk, females are at a higher risk, and I just kind of list the risk factors. And potentially, this could be a reason why you develop frozen shoulder.
Good. So I want you to have in the back of your heads the patients you've treated. I also want you to have Marie, my sister-in-law, who is microbiologist by trade. That's what her master's degree is from Davis, and now is in marketing, sales, and still in the lab for a startup firm with the Biorad for 15 years. Really intelligent person. I love her dearly, but this is, first she's family, so it's already a tough treat, right? She's a scientist. Tough treat, just from telling me everything about this. So have Marie in the back of your mind. At Christmas last year, it's like, hey, Brian, can you look at me? Look at my shoulder real quick, right? So, because if you tell her, I don't know why this happens, she's gonna look it up, right? So how do you guide a patient into their own lit review? Because your average patient's looking stuff up nowadays. Am I right? I mean, what percentage of your patients do you think look Google? They're
85. Unless they don't know how to use it.
This is true.
So go to the library.
Right? Or the friend.
Oh, yeah.
And my aunt said, right? So think about that. I'm not going to give you my viewpoint until we get along with this, but just think about how this goes. So the post-traumatic, post-surgical patient, we want to be using Steve Schmidt in the back of our head as well of pain sciences, is patient education. So on a post-traumatic, post-surgical patient that's starting to get really tight, how does that differ from this patient? Right, so if you have a person who's highly fear avoidant, post whatever shoulder surgery, and now they're here, right? How does that relate? Because again, the other patient I just saw in the last 2 weeks, so saw her right after Thanksgiving. She came from Roseville, is the wife of the assistant director and the PT and inpatient up there, and he's broken on the phone. Never heard him break down like that. And I was commuting from Fairfield into Vacaville one day, and I said, he was at a poignant moment of, dude, I don't know what else to do. Really heartfelt conversation and trust. And then there's one little spot between Fairfield and Vacaville, you go through some hills, and about 1 out of 10 times, you'll not drop the call, but it'll be a 10-second little, it's on my phone. So I thought that's what had happened. I said, Bill, I'm so sorry, I lost about the last 15 seconds. And then he came back on and said, I'm so sorry. He couldn't talk anymore, he was crying. So this is 6 months post-impact fracture, greater tuberosity, and humeral head fracture, you know, in someone who's not quite 50, active, fit, data analyst, you know, person who's now 6+ months in and is petrified that she has, in the words that she uses, I've had a frozen shoulder on the other side, I never want that again. And on this side, I think I have complex regional pain syndrome. And so I think they're gonna send me to a chronic pain program where we just talk about our misery until we die. Her words. You're like, easy now, we're talking about frozen shoulders. Well, this was my last frozen shoulder, right? I saw her, God help me. I used to make fun of Michael to his face, so I'll still say it behind his back. Like, dude, that was a treat, man. So when I left her, it was 1 hour and 40 minutes, and you don't have that luxury. But she also came down from Roseville, and I know I have one shot at this very intermittently, to have them make that trip. So the way that we talked, and the degree that we talked about this, from her talking about misery and death, like, holy cow, we're in it. And this is a super normal analytical person, no reason for this. And yet, the reason she's talking about misery and death, and she was developing complex regional pain syndrome, the typical, I mean, the turgor of her skin was off, she had a sheen, she had supraclavicular fullness. It was, I mean, literally the pallor of her skin was different on her symptomatic side versus her non-symptomatic side, and she was starting to get pain that was starting to creep into her other shoulder. I mean, it was on. So all of that, and yet her biggest fear was getting a frozen shoulder on this side. So at that point, just spoiler alert, I told her, I can't wait for you to have a frozen shoulder on this side. I love frozen shoulders, they're the best. They're not great, but we know what they are, and we know when they get better. So your doc she saw 2 Kaiser orthopedic surgeons and 1 outside that they paid for. And all of them had the same thing. Oh no, you only have this much range of motion, you're probably gonna get a frozen shoulder. So it was like, your worst case scenario is coming to roost right now. I can't believe you only have this much. So remind me to come back to this case, because there's a powerful intermediate between seeing her 2 times. The first time I only saw her for 45 minutes, the second time 1 hour and 40 minutes. Because it was like, we're at a crisis moment here. And so this little 2 roads diverging in a wood is an important one. So how you talk to your patients is important. Because this, people get a lot of fear, and that I think we enhance fear avoidance a lot with patients by saying, oh, if you don't do this, you're gonna scar down. And yes, post-traumatic and post-surgical are much more difficult to deal with, but the whole point is, why are they gonna scar down, right? So what is going on in their mind, where they're over or underdoing it, that's making them go that direction, versus this one, we see this a dime a dozen. So with a post-surgical or post-traumatic, you're talking about true scarring, you're talking about focal capsular contractures and dense fibrous adhesions. They're a different type than idiopathic. Similar vein, but there's a lot more factors that are just truly going on true muscular and capsular joint restriction. Obligate translation. This is an example of an idiopathic situation. So old school, multidirectional instability, we're just going to tighten the crap out of the anterior capsule. Normally though, that if you over tighten that, you're now going to push this obligate posterior translations. It's called posterior impingement, where then that literally tightens so much anteriorly, it's pushing the entire humeral head backwards, and now you're impinging, and it really enhances the probability of glenohumeral OA. So you're just beating the crap out of the backside of your glenoid. We have redundant capsular stuff here, which is more likely to kind of then freeze up throws you into a little external rotation, but then you're limited in your end of range of external rotation. And if you've ever seen someone who's been over tightened, it's a tough patient to get improved. So that would be someone who you think, well, are they frozen? Like, it's been a long time that they've had this going on. And then you're gonna stage that according to its irritability and inflammation. So overall, in the idiopathic front, it's 3 to 5% of all shoulder disorders. I think it might be more nowadays, but regional capsular contraction. Most notable contractions are gonna be inferior and anterior capsule. We'll talk a little bit more about that in another slide. Women definitely greater than men, 70 to 30, and then if you say self-limiting within 2 years for 85 to 95% of people, how is that? How do you use that in your patient discussion, education, and prognosis? And this is a super deep question.
I might be oversimplifying it, but it's just kind of like, this is a really tough, it might be painful and tough and it's a bad wave, but you're gonna write it out and it's gonna get better. It's kind of just like.
I love that. Right?
Yeah.
Maybe one more. Did a lot of family patient care this holiday season. I asked my dad on the way in this morning, I said, what L4, L5 ridiculous? Never had any ridiculous pain. What first treatment was over the phone at Disneyland? I was in Disneyland. So he's scared. Never had anything like that. He said, Ryan, I'm telling you, it's numb. Like I can, it's like numb. Like kept hearing him tap his legs. It's first stop tapping your leg. It's also hypersensitive, so you're not gonna like that. I just been massaging the daylights out of it. I gotta get that feeling back. Oh man, sure enough, like 3 days later, he's like, it hurts so bad. Like it's hypersensitive. So I said, like a sunburn? Exactly like a sunburn. Yeah, you got a nerve that's screaming, and whether it's saying I'm gonna go take a sick day today, or it's just gonna scream at you, it's not sensory and motor. It's not doing good. The most powerful thing he said I told him was, I've seen this before. Did you say that to your patient? Sometimes I would, to just tell them and with some reassurance, this is, yeah. So, what you have is X, Y, and Z. We see this a good amount of times around this place, right? So it's like, and if it's low back pain, it's a little ridiculous something, you're saying, I got 6 more patients today, probably 3 of them are almost exactly what you have. So in other words, this is something that we see a lot and we know how to deal with it. The flip side of this though is, think about what 15% of people, when you say something self-limited at 2 years, and we'll take the average, 10% of those people, 1 out of 10 is not gonna be improved at 2 years. We gotta tilt our head at that. That's way too high for us as a profession, therapy, ortho, the medical profession, to say, oh yeah, frozen shoulders, idiopathic frozen shoulder is self-limiting within 2 years. Yes, and that's the right first line. But we just need to make sure that we're understanding that patient's plight, so that if we're at 18 months or before 18 months, we're at 6 months and we're seeing, is there something this patient's doing to propagate or perpetuate this? Because you can stay, I've seen this a lot because I did it to people, you can stay in an inflamed state because of what you're doing. So I'll just throw that out there. Because we think of these nice little freezing, frozen, thawing stage, we'll get to that in a second. You all have seen that before. But you can keep them absolutely red hot. And I think that's what you're going to see in a lot of patients' responses to frozen shoulder in physical therapy is, yeah, it was pain and torture. They just kept making it chronic. So risk factors, we already stated diabetes, yes, insulin diabetes, dependent even more so, but thyroid disorders, hyperparathyroidism, hyperlipidemia after an MI, chronic bronchitis, all of those things can be stuff that tightens you down. They used to think that that was just something that was related to, you know, holding your pillow, right? Chronic bronchitis, trying to kind of tuck in as you cough. But now they're thinking there might be even more kind of an inflammatory marker that can, you just have a lot going on if you're in a quadrant with that. Obviously, around the middle years, 40 to 60 years old, is the highest incidence of this. And this is important because you'll see this a lot in the literature. The rotator cuff interval is in between the subscapularis and the supraspinatus tendons. So it's this interval of space here. So you got your coracoid process here, you have your coracohumeral ligament here. And this is where in the histologic and even a lot of studies that have looked at frozen shoulder and done arthroscopy of it, this rotator cuff interval is really important because the thickening that occurs there and then creates a reduction of this axillary fold is a really big deal. So a lot of folks will see that this superior thickening of this coracohumeral ligament is one of those kind of hallmark factors if you're looking at the shoulder. Now, have you had anybody other than Jenny with her post-op, her post-minute patients, do you have anyone having surgery for frozen shoulder? Has anybody seen somebody with they scoped a frozen shoulder?
It's not even it, right?
Just minute,
Just
yeah.
minute,
And the minute, they're not doing any scoping with the minute.
I can't remember. It was during rotations.
Did
Here?
they do a scope? No.
Okay. Okay. So, because again, it doesn't surprise me that you're all thinking, it would be very surprising if you all said, yeah, I'd have one of those, because that's just not done very often. In other words, when you introduce a scope into a frozen shoulder, depending on the staging particularly, you ain't doing it any good. All you're doing is trying to get through that stuff, and then you can, okay, now what tool are you going to use to get through this true inflamed capsular thickening, right? So the manip is much more in favor, and we'll go through that a little bit more here. So you got hyalinization, you got fibrosis, you got loss of the synovial layer. There's all these histological changes that are going on. And the one thing that I would say, just to answer my own question, what do you tell a patient? This is my answer, and you can determine your best. But what I say instead of, we don't know why it's happening, and kind of leave it that broad and cold, say, it's a true histologic change. In other words, there's a reason it's happening. There's just not something, you haven't done anything, unless they have, like they've been in a sling for the last, for your voyage or whatever else, it's kind of more iatrogenic at that point. But if it's a true natural history idiopathic frozen shoulder, you're gonna tell them two things. You didn't do anything wrong, number one. And number two, we don't know why this happens, but that tightening of that capsule becomes inflamed, and then it adheres to itself. So adhesive capsulitis. As soon as you say scarring, I think that evokes an image, right? Because that's post-traumatic imagery, isn't it? We're really being careful about our terminology. So it scars down on itself. Well, crap, how do I get rid of that scarring? So adhesing to itself, adhesion in my mind and in the majority of my patients' mind is a much more palatable term. And plus it takes them back to, what did you call it? Adhesive capsulitis. It's just, it becomes sticky. It adheres to itself, the capsule. And this is similar to a few other areas that we have in the body, right? Dupuytren's contractures. There's these things that you'll have seen, and that seems to really help with patient education. You have a lot of people who have had someone in their family or friend group that has had a Dupuytren. It's like, you just do this, and they're like, oh yeah, and they can't really undo that. And so it's not a trigger finger where you can pop it and it pops back down, pops and pops back down. It's literally, it just adheses down. It's the same histological factor that we're dealing with Dupuytren's. And then the other one that I would tell every patient, that you can put it in there, but it's just for your minds, Peyronie's disease in the male penis is the same histological overall vibe, right? That would create a bend in penile tissue. So those are our three histological family that say, okay, we don't know why those happen, but we know that we're more predisposed with diabetes, et cetera. So when you're educating your patient, let them know, because going back to my sister-in-law, that was just reading her analytical scientific mind. It was like, what do you mean you don't know? Like, everything has an answer, right? Amino acids, proteins. Mad cow disease, we do this, and we develop a test for it, and then we go, it's just, what do you mean? Like, are you that? Because her mindset, and this is important, is I'm middle ground medical. Well, she hasn't ever told me that, but I just know that that's the case. You know, there's surgeons and people who fix people and cure cancer, and then you're, I don't know what you do, right? You help people get stronger or something, I don't know. So all that being said, as soon as I say I don't know, and she's not sure she's in the right spot, then that's no, then I'll go figure it out. Because she's gonna go PubMed the crud out of it, right? So she's got all the journals that we could get, so I'll go find out myself. So even telling an analytical person that way, so as you go and research this for yourself, here's what you're gonna find. And that's what I think that helps these patients, especially a highly analytical patient, understand this, so it's not just like this external thing that's happened to them and no one in the world knows why. Because I've heard a lot of us, myself included, say that, and I don't know anybody that really helped, right, in real time. And I want you to challenge me on that. Do you think that's helped anybody in your experience? You don't know why it happens. It just becomes more nebulous, more outside of my control. Back to your point, Jenny, like what can I control, what can I not control? That's what patients are looking for every session that we have with them. And sometimes when we get out of control, we don't know what we're gonna give them, and so we get caught up in a story, and it is the big picture, crud, and everything hurts. So now I don't know how to give you a piece of, partial this back down to a bite-sized piece where you can have control over this, and this is how you're gonna keep scientific in the way that you do these exercises, right? Pathophysiologic staging back in 1987, they did this. They have not repeated this study because you don't want to, period. So this was, they scoped everybody. And what they were looking at is what does it look like, literally. So they staged it stage 1 through 4. Localized inflammation of the synovium was a stage 1. That's a hard stage, even from a histological or an arthroscopic standpoint, because there's a lot of things that have capsular irritation. Does that make sense? So you can have capsular irritation in the knee, you can have a capsulitis, a bunch of different ways. That doesn't necessarily go to full adhesive capsulitis, but that's stage 1. And then synovial redness overtly, adhesions of that axillary fold, loss of that subacromial space, thickening of the capsule. Then it goes into pink, so this is the most irritated, then this pink synovitis, but you still have this 50% loss of that axillary fold, and then severe contracture, but no visual arthroscopic visualization of this redness or pink synovitis. This is also an interesting one because they're trying to stick a scope back in, and it's hard to scope a frozen shoulder. Like they literally have difficulty getting the scope into the joint space. It's that thickened. So keep that in mind when you're thinking, okay, how does this look or feel inside? They've done that. Here's a couple of things that I pulled up that are from scopings that have happened for other reasons, but it just, you see that's hot, red, irritated space. Mm-hmm. So this one is inflamed synovium capsule over the infraspinatus, and then this one here is just inflamed and contracted at the rotator cuff interval between that biceps tendon and subscapularis. Yeah. This is a famous slide. So does this help people? And do you use this?
I think this one has really helped me with some people. Like I had a lady recently who was just super upset and emotional. She was like, I'm trying to do lots of stretching. I don't know what I'm doing wrong. And so it was letting her know, like, hey, nothing you did was wrong, but this is the phase you're in, and this is what I'd expect. So this phase, rein it way back in. You don't need to do all of that. And then she So we talked about the phases and going through, and then within a couple times she was doing so much better, and now she's like doing way better on her motion, and she was getting into that thawing phase, but making it concrete and taking
Yes.
away the guilt, I think, made her realize, oh my gosh, this is great. I don't have to have my family members tell me, well, you just have to stretch more, and like, you know. So then she was a lot more positive and just, yeah, felt way better. So she was able to swim on her vacation, which was our goal, to get
Wow.
her over the holidays to go to
Right.
Bermuda or something, so,
Good.
or Bahamas, so yeah. But
It kind of goes back
that's
to
cool.
your case with that, the patient that you're treating, they stop for 2 visits, like, you show them this picture, and, you know, like you said, fear avoiding words, right? You have adhesive cap or frozen shoulder, but you show them this picture, like, no, there is a progression of timeline. Like, yes, I'm glad you have it because I know what the outcome at the end is gonna be. Like, there is hope, and you show them this picture. And just like Tina said, like, yep, you're in the frozen phase, so let's just relax and chill, you know, do everything else that you can, and then, you know, when you get in the thawing phase, we're gonna, you know, progress.
I think I add too on there, like decreased range of motion, increased pain, like that, I add in there when I write this on a paper for them. And I write the numbers more, because then it's a little more concrete too.
Huge.
Yeah,
Knowing characteristics of each stage is golden for patients, because they don't know that there's an end in sight, you know, like, is it gonna be like this forever?
Absolutely. So, like, if you have if you hear nothing else the rest of the time, I think every true adhesive capsulitis patient has to see this. I used to do it on a whiteboard, and now I do it on paper so that they can take it home. Like, no joke, and then I fill this in more. So this is the original from Rowan and Lefford in '82. This is just how they said it, right? I say 4 to 6 months in every stage. So on each stage, 4 to 6 months, 4 to 6 months, 4 to 6 months, just to kind of give them a range. The other thing that I try to do is to tell them everything about frozen shoulder. Nothing has anything to do with temperature or freezing or frozenness. It's all a misnomer, but it gives you, all we're talking about is tightness. Like that's where we are. So freezing, it's almost the opposite. You're inflamed, right? So and I think that helps people, where you're just saying, let's break this down. Because if you just said you didn't do anything wrong, this happens to people, you're in the right decades of life for it, and it's idiopathic. So yeah, we have no clear-cut definition of why, but we do know what. We know what it is, and we know this is the progression of things. So I'll literally say this. The freezing phase is the opposite misnomer. So you're gonna be more inflamed, more irritable, and that means you're gonna have a lot more pain. Then that frozen phase, and during that, you're gonna lose your range of motion. So you're gonna start losing more and more of your range of motion. And our goal is to try to keep that somewhat capped. I don't want you in a sling. It's not time that would make things worse overall. It'll prolong these stages. So will over-exercise. So with my sister-in-law, that was the key. She's thinking, I'm going to a physical therapist. You're gonna tell me movement and stretching and strengthening patterns that will help this condition. Because what condition would movement, stretching, and strengthening help? She's very active and has a great viewpoint of life like that. This was the only thing that got me to even have her stop and pause for a second. So if you were my brother-in-law and I could see you, if I went to a physical therapist and I saw you 3 times a week, I'm like, no, don't go, because of where you are right now in this process. And she's trying to grind. I mean, ironically, she was using her, she kept doing dips on her, like 5 foot at max. And she kept grabbing onto her, your hand close, help me.
Hold me? A clothesline?
No, sorry, like
Pull
your
it by?
hangers, closet.
Oh.
Oh, the closet.
Closet hanging thing.
The rod, whatever.
Yeah. Is there a name for that? That
Rod?
I'm thinking about?
Closet rod?
No?
Okay.
Right.
Always the same thing. So she kept just dropping to, just trying to torque her body weight to go into a squat and crank it. It was killing her. So to be able to say, stop that, I don't do that anymore. And then, no joke, I can just bring them in the room right now and hug them and apologize for how many people I flared early in fellowship, saying, I know what this is, and I'm gonna try to stop it. If you're freezing, bite this, it's gonna hurt you more than it hurts me. And it was bad. And if you have that frozen shoulder patient and you're banging away with manual therapy at them, I don't know that we help people in this freezing and early frozen stage. What we do have, and I'll show a little bit of evidence for, is this is where the intervention with an intra-articular injection has a shot. So this is an important point as we relate to these patients. 2 years for a self-employed mechanic or a hairstylist or someone who's manually doing stuff their entire life, easy for me to say. You're telling me I'm not gonna be able to raise my arm much more than this, and it's gonna be better in the next 2 years, and I can't expedite this? If it's at a point where it's freezing and then it's highly inflammatory, and mark my words on this, where passive range of motion starts to be limited as much as active range of motion. Not as, it doesn't have to be the same amount, but a lot of these patients early on, the differential is tendinopathy, right? You've got a subacromial impingement. So, or they hurt their shoulder somehow. Ouch, it hurts, and then that starts an inflammatory process that ends up in adhesive capsulitis. So you don't know that at first until you start to say, because your average tendinopathy is going to have full passive range of motion, right? Maybe sore at end of range, maybe sore through range. When you start to get, that's all you can lift, and I can't get any higher. That's where early a decision needs to be made. And then I'll just reiterate, don't let it be a subacromial injection. Like I will truly tell you, don't even let them get that. So this would be where you need to help intervene, and then that's when it would be use your networking, right? So whether it's one of your mentors or whomever, because I don't know anymore who does them. You guys know intra-articulars? Because even a lot of times the docs will say, even a primary care doc, if you just say, sure, all they're gonna see is shoulder injection, sure. I'll send them to ortho for a shoulder injection, and that's all they're in for. As opposed to our orthopedic, non-surgical orthopedic PAs and docs now are really darn good at trusting us, especially when it's a therapy recommendation. And I always ask it as a question. Could be a really good candidate for an intra-articular injection. What are your thoughts, right? Like, can you see this patient? And that's one, like, just save them the rigmarole of a video visit or a telephone visit or whatever else. It's like, no, this is one that they can go and get done in the same day and be done with it, right? So, especially in our system. One reiteration would be, you wanna have imaging, you wanna have plain films before you do that, preferably. But if you're seeing them the first time and you're saying, oh, here's the history, and I think they're at this stage already, they've lost a lot of passive range of motion, I wanna see if I can expedite them through, then by all means, you can just say, hey, can we get plain films ordered to the shoulder, and then an ortho referral. And again, that's not a referral you want to make unless what is the precursor to that. Ortho's gonna see them for one single reason, for an injection.
You need to see them afterwards.
Good. But I mean, even before you send that referral to ortho, you need to have the discussion with the patient. Are you okay with the long needle? Right? Because otherwise it's a complete waste of that patient's and their time. And then, again, hear me on this, our nonchalance in the medical community around the frozen shoulder, being self-limiting, blah, 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 can bite us in the butt when you send them to go and see a subspecialist and they don't have any more answers for them. Do you guys really know what you're talking about? And maybe advanced imaging is needed. How do you know it's what you think it is, right? All you have is an x-ray. Wouldn't an MRI be more powerful for this? We'll talk about that more.
Right, sorry, the intraarticular injection would be for freezing and frozen, or just freezing phase?
You know,
mostly?
like
In the
here.
middle, okay,
Yeah.
because they already lost a lot of motion, you're starting to lose more passive.
They're starting to lose their passive motion, they're highly inflamed, like everything that would scream cortisone. You know, it's biting me, it's keeping me up at night. I mean, those are the ones that, because there'll be some that are painful, but just with movement. So like literally think about that, because that's a great question. It's important that you're saying, bluntly, take a step back. Is there anything about you that's inflammatory? That like is classically irritable and inflamed? And if every bit of your frozen shoulder diagnosis, you're gonna have some that literally are, I can't sleep at night, I'm trying to figure out, and it's bad. I mean, a bad frozen shoulder is, I put it right up there with a really hot radiculopathy. And yet you're gonna see some really kind of cool frozen shoulders that are very mechanical. Man, if I do a quick movement, it bites me. And so their main complaint is, you know, oh, I'm trying to flap my alarm off, and it just, oh man, how long does that last? 30 seconds, but it kills me. And then that chills, yep, as long as I don't do quick movements throughout the course of the day. So think about that. That patient that's very mechanical and not a high amount of irritability on that relaxing front is likely one that probably wouldn't get a ton of help with an intra-articular injection, right? It's just not, it's not that inflamed. That one that is so inflamed, man, that it's just, they can't move, they can't find comfort, that's one that earlier on would be helpful.
Is there any, I think in Brazil, I heard of maybe a nerve block for
Yeah.
frozen shoulder?
I've heard of it, I'm not
Okay.
real familiar with it, but they've done a ton around frozen shoulder, right? Around capsular distension, around a whole bunch of different things have been in vogue for, a few years, and then it just didn't help expedite this slide, right? The one other thing about an intra-articular injection though is, I'll slide on this in a minute, but it, in a weird way, from someone who really knows what they're doing and has injected a lot of intra-articular shoulders, they'll be able to tell you it's really pathognomonic. So they're gonna say, if it's a true frozen shoulder that's advanced pretty solidly, it is hard for them literally to inject anything into that joint because it's true story, it just doesn't have the capsular distension. It's all locked up and they can't, the plunger is hard to push. So seeing Dr. Hazrati post-manipulation do intra-articulars with some of these patients, she tried it even doing a pre and post before, trying to do the intra-articular just to kind of get some analgesic and stuff and then do the manip and then, okay, now let him go. And seeing her try to push that plunger in on that patient, gosh, like literally. Oh. Versus afterwards, it's just like, it was there. So an interesting, and, getting ahead of myself, but all the MIPS that I was in on, that she was in on as well, it was always interesting. It's just cool to see a dog sometimes work in. She would always, right as she was getting towards the end of the meds going in, she would pull back out, just suck back out. Every time she's like, I can't believe this. So every time it was hematose. So every time it was bloody after what we had done. And she was so impressed with Michael and me being able to do a manip so non-violently, because they were just used to, ortho was just doing one lever. It doesn't go this way. Just, blow it out.
Yeah.
And when we were doing, little physiologic movements, she just couldn't believe that those had done, created blood in the joint.
So you went in with her to do the manip under anesthesia? Is that?
Yeah.
Ah.
So we did.
Oh, that's really cool.
Probably, I think I did 7, and Michael at least that amount, where we were the manipulator, right?
That's awesome.
We'll explain a little more about that in a minute. So, Freezing. Gradual increase in pain, it eventually gets intense in most patients, similar to that progressive rotator cuff tendinopathy. It's refractory to typical intervention, in other words, it's not getting better, they're resting, it's not getting better. Gradual decline in function, avoidance of that range of motion, and then near the termination of that freezing phase, they'll lose that accessory range of motion. Intra-articular cortisone injection is strongly injected, it's strongly suggested at that time. So somewhere in here, and that's where you can tell your patient. So if you're talking about that, you say, hey, whether you're leading up to it or whether you're recommending it, you want to have that discussion. Hey, this is highly inflamed, I know you're in a lot of pain, there is something that we could potentially do that's through orthopedics. It would be an injection into the joint itself, educating them, so then if they, oh no, there's no way I want an injection, well then you're done at that point. You're just letting them know the pros and cons of it. So frozen, gradual decline in pain intensity, gradual and marked decline in range of motion. So as your pain gets better, your motion is generally stiffer. Mobilization at this point is generally low yield. I'll say that manual therapy wise. You're going to do some manual therapy up here because you're looking at AC. You're trying to treat a shoulder that you think might just be a tendinopathy, and then your short-term goal should be maintained and will restore range of motion. And this is a bang term. I just kept craniofacial hygiene. Remember, and I would go the opposite side of the fence as well. There's two things that a patient with a bad frozen shoulder is losing their range of motion want to do. And they're to wash their face in hair and wipe. Right? So telling someone, you're just gonna have to learn to go lefty for the next 18 months. That's not great. Not good news, doc, right? So thinking about that, when we're so cavalier, oh, this is self-limiting, it's gonna be great. Remember that. And then when you're talking about the frozen phase, generally a capsular pattern. This is the old, Syriac's capsular pattern, external rotation more than abduction, more than internal rotation. It holds pretty true. We'll talk a little bit more about some modifications of that, but I mean, it's restricted, let's put it that way. And then this is key, getting back to things that we wish that we were able to do. We're gonna do a very short lab of I want you just to pause as you were doing an accessory. You guys have done accessory at the shoulder, right?
Mm-hmm.
Yeah. Literally, I want people to just lay down briefly after break. You step back. Instead of I'm gonna do a PA, I'm gonna do a this or a that, just like literally feel the shoulder. Is that person giving you their shoulder enough that you understand what normal feels like all the time? Like that, this is a normal physiologic accessory motion of the glenohumeral joint. Because then you see this hard spasmy infield, or that leathery infield, that's the other thing that really pissed me off. It was like, what do you mean leathery feel of a shoulder? Like I don't even know if I'm on the glenohumeral joint right now and feeling that motion, much less interpreting the findings that are coming back to me. So that we can demystify that a little bit. And then thawing, we'll take a break. Stiffness is dominant at that point. Quick movements can still bite you. But you're looking at motor planning, gradually getting some spontaneous return, and then this is where you can start spanking them again, right? You can, hey, it's not hurting very much at all. Good, let me get in there and see if I can get some, I'll battle axe you for a half hour, see if that has any effect, see if that starts to help you break through this a little bit quicker. But the whole point of this is not a weekly therapy. I mean, this is you making the call based upon your patient's compliance with your program. And your program has got to be not having people constantly do the aggravating factors. So if they're still pushing through it, they're trying to stretch, they're trying to strengthen, they're trying to look at YouTube and say, I don't want a frozen shoulder. You already have one, and it's evolving. So giving them, here's what to do, and here's what not to do, and here's this, how it fits into this big picture is money. Let's take a break. Yes.
Quick question,
Yeah.
the peak between frozen to thawing, right, in that kind of lowering interval injection at that phase?
I don't know of anyone who would, other than, true story here, Corey, if we were Bobby Cryer, who might be going back and getting kind of an advanced physio, where you can inject and stuff.
Yeah.
what I think might be beneficial at that point on a few patients, would be interested to try on a series of 10 patients, would be to see if just doing the capsular distension, pushing the crap out of saline into that shoulder might pop something from the inside and kind of open that thing up and then expedite you through that last 6 months or so. But as far as the corticosteroid, no, at this point they're not having a lot of pain, it's not inflamed, and so the infection doesn't do much. It's a good question. Good, take 15 minutes.